My name is Callie Littler. I'm one of the AMPs in the acute care team. There are 4 of us. I started out as an anatomist, but I've been here at Warrington Hospital for 12 years, and I'm here to discuss with you MET calls, the handover processes, and what happens out of hours here at Warrington Hospital. Welcome to the Trust. So our aims and objectives from today are to provide an introduction to the acute care team. Not every hospital has one. To then discuss the medical emergency team and the response that we have here at Warrington Hospital for emerging illness, and then to highlight the electronic bleeping system, which has been in use for just a couple of years, and we've made some changes to the handover, which is only embedded in the past 6 months, so you are as fresh as the system. So the acute care team is a group of acute care nurse specialists, all of whom can act in the critical care outreach role, and some advanced nurse practitioners, which is an evolving role. I'm the first one from the trained perspective, but we have 3 trainees coming through the system, and they're all really established nurses, the whole team, that have been here for a number of years and can help you to orientate and understand local processes, especially in the out of hours period. We also form part of the medical emergency team and the cardiac arrest team as well. We can do all the normal clinical skills that you would expect from an outreach or acute care team. So we can cannulate, we can do blood gases, arterial and venous, we can do ECGs, male and female catheterisation, but we can also do basic airway management. We can insert eye gels and we can lead an arrest as well. We're all ALS providers and have been for a number of years. So if you're looking for any support out of hours, we are definitely part of the furniture here at Warrington Hospital. Whilst we do lead a MET call or cardiac arrest call, that is normally down to you, but if there is a number of calls at the same time, there's no need to panic. We are here on site to help. This next slide talks about some of the roles of the acute care team. I'm not going to go into them in detail because you can see from the slide we do an awful lot. We cover surgery, orthopaedic, gynae, medical. If it's an inpatient adult specialty, we are involved. We don't come to the ED unless there are concurrent arrests, in which case an arrest might go out over the pager and we'll attend. And we don't cover paediatrics either, although if there is a paediatric arrest on the ward or elsewhere in the hospital, anywhere other than ED, we'll come and act as runners to support. We will see all of your fractured ribs patients. If you're a surgeon, you don't need to refer to us in that instance. We will just turn up. That referral should be placed in ED. We also see anybody who has a new score of 5 or above, which is part of the national RCP expectations. So we're here to support the patients in a variety of ways. We also cover critical care outreach. So if you have a patient who needs to go to critical care, then we will be the people who will help you to do that, and we will facilitate the transfer in. And we also hear about every discharge from intensive care or high dependency to the wards. So we're your liaison between critical care. So part of your role will be the MET calls. Now, not every hospital has a MET call system. Some have a very robust one. Ours is quite a junior-led medical emergency team, so I'm going to discuss what your juniors will be doing and ask that you support them in fulfilling that role. So MET calls, as I'm sure you all know, is designed to bring immediate help to the bedside for a deteriorating or critically ill patient in a general ward environment. And here at Warrington we have 3 teams. There is a medical team, a surgical team and an orthopaedic team. So whichever specialty the patient is under, that's which team will be summoned. The gynaecology inpatients, they will have a surgical MET call. So if you are a surgeon covering the MET calls, please don't be alarmed if you get there and there's a gynaecology patient. We really would appreciate your help in that instance. The MET calls are only for inpatients. They are not for corridors, outpatient areas, CT scan, ED, the car park. We would expect that a cardiac arrest call would go out for those patients because our MET team is junior led. However, if we hear a MET call to any of these areas, we will turn up. So who's on the MET team? It depends on the day. So Monday to Friday, 9 till 5, it is an F1 that's expected to respond, and that's the post-take F1. So they will be pulled off the post-take ward when their pager goes off, and they have to present immediately to wherever the call has been placed. One of our team will go, often 2 if there's availability, and if we have an assistant practitioner available to support with some of the clinical skills, then they will also come as well. Then in the evening, so twilights and overnight, we expect the SHO to attend. And to be honest, we tend to get an SHO during the days as well. It seems a good learning opportunity. It's always good to have as many senior people as possible at these events. For orthopaedics, this is the difference. It's an SHO at all times because we understand the F1 in orthopaedics tends to be very ward-based, and our orthopaedic patients, especially outliers, can require that senior level to establish. So if you take a look at the slide, please make some notes and make sure that you are happy and aware of your responsibilities and your role when you start here. Because we have a junior Met Call system here, rather than a registrar having to come to the Met Calls, we ask that the registrar comes and reviews Met Call patients at the earliest possible opportunity. So if you hear a Met Call go while you're in ED, and if you're a medical or surgical registrar on call, we would like you to then come to the patient area where the Met Call was placed as soon as you can. So it doesn't have to be immediate like it does for SHOs. If you're a CT or an ST undergrade of 3, then it's an immediate response. For ST3 and above, come along when you can. Often these patients need a discussion about escalation of care to critical care, or maybe palliation, maybe some ceilings of care, but we need that senior decision maker. So please come along when you can. The exception to this is if we get to the Met Call and we find that the patient is severely ill or needs decisions made now, we can fast bleep you, in which case it will come over the pager and you can attend appropriately. So please be aware that you might get paged. So what happens at the Met Call? It's very simple. It's an A to E assessment of the patient, starting with airway. Met Calls can be called for a variety of reasons. Now, the most common is a new score of 7, and this is pretty much standard across the board, so you're probably used to this already. Anyone with a new score of 7 needs an immediate response. But it can be a partially occluding airway, it can be a tachypnea, it can be a severe hypotension. There's a variety of things that call us there, but every time we get there, it's the same thing, it's A to E. We try and stabilise the patient. Often we'll initiate the sepsis 6 or the sepsis care bundle, so we expect those to be done. And then a management plan to manage the current illness, and any adjustments to the ongoing plan of care must be placed into Lorenzo at the time. We're facilitating an urgent response to a deteriorating patient with the outward goal of hopefully stemming the deterioration and keeping things as they are. As I mentioned, it should be an ST3 or above that reviews the patient at the next available opportunity. Met Calls, we have normally about 3 to 4 in any 24-hour period, but it varies, and often they can be very simple and almost monotonous, but we do ask, if possible, please treat every patient with fresh eyes and go to the patient first rather than looking at the patient care notes, because often there is a bit of a mismatch about what's going on now and what was seen on ward round. That's it for Met Calls. I'm going to move on to medical handover. Trying to keep things nice and neat and sweet for you. So medical handover, Monday to Friday, is at 9 in the morning, 5 in the afternoon, and 9 o'clock at night. Surgical handover is at 8 and 8, orthopaedics 8 and 8 as well. But medical handover here has taken a lead in making our processes more organised and slick, and this is being disseminated across the other specialties, and I think the surgical team have taken this on board in the last month or two. It's been shown to improve patient safety and the amount of time we spend in handover. It's really cut down. You can see on the slide we have a set protocol. Linda, our organiser, she will fill in the paperwork Monday to Friday. It doesn't necessarily need to be done at the weekend. We do ask that you attend promptly so that we can all get away on time if we are leaving the team. Anybody coming to medical handover, it should be the leaving on-call team, the on-call team coming on duty, and then anyone who has anything else to hand over. At all times, bar Saturday and Sunday morning, this happens in a combined assessment unit. There's a specialised room there. But because of COVID and having to socially distance, at a weekend on a Saturday and Sunday at 9 in the morning, we've now moved to the Trust Conference Room, which is on the first floor next to intensive care. So if it's a Saturday morning or a Sunday morning, please come to the Trust Conference Room. All other times for medical handover, it's the combined assessment unit, and that is a new change because of COVID. At the handover, we follow this protocol, and it stops you taking the bleeps home at night. It helps us to establish who's who, any rota gaps, anyone who hasn't turned up. And if you're late to handover, it's expected that you will contact the registrar to let them know that you are on site afterwards, because we'll try and fill the gap otherwise. So we have this protocol here, as you can see, we run through introductions, we hand over the pages having cleaned them, and then move on to any rota gaps, and then this safety brief escalation. Now this is your opportunity as clinicians, if in the previous shift you found a safety issue, to voice it. And Monday to Friday at 9 in the morning, the acute care team, myself and my colleagues, will then run with this information to the trust-wide safety brief that happens at 9:30. It's vital, if there is a problem, especially in the on-call period, that we do something with this. So if you're filling in a datix for any reason and you need it discussing at a trust organisational level, please tell us and we can take it and action it, rather than keeping it small in the group. Things don't get changed that way. Okay. After the safety bits, we move on to any ITU admissions. We will let you know if there are any ITU discharges out of hours that we might need a medical review, or have any ongoing problems that will need addressing before the next ward round. Recurrent met calls are discussed in thorough, and then the unwell patients. Unwell patients are logged electronically. I'm going to go on to discussing those. We also have non-urgent things, so if the patient is not unwell, you don't need to attend in person. This is trying to keep the numbers in the room down and also keep the amount of time we have to spend down. So I'm going to run through this slide here. So routine jobs, such as overnight, can you please chase the x-ray? Can you check the bloods after a transfusion? For daily fluid management, so a patient who's nil by mouth and who needs guided fluid management, you can put an electronic bleep out for your colleagues to receive with a time that it's needed by, and you don't need to come to handover to hand all those tasks over. They'll be established on the system. So if it's just a task as simple as check HB after transfusion, log it on an electronic bleep, and we'll cover that in a minute. But if the patient's unwell and you need to come in person, you need to add them to the electronic medical handover list. And both of these things need to happen by 4:45 if it's the afternoon, to make sure that they're ready for the 5 o'clock handover. So looking at the medical handover on well patients that you're going to hand over in person, you need to use e-outcome and you need to make the patient medically prioritised. Now this will be covered by your IT session, so I'm not going to tell you how to do it, but the reason why is because it presents on this screen, as you can see. It will list the patient for discussion, and we will go through in the handover patient by patient. On the right hand side of the slide, you can see that there's medical information. You just click into the box. Again, the IT will teach you how to do this, and write down what you need to happen. So if it's a daily registrar review for a GI bleed, you put that detail there, and you put what the escalation status is of the patient, so that when you go home, whoever's taken over from you can refer to the electronic list to get that information. So the routine tasks, this is what it looks like when you're putting the tasks onto the system. These can be logged from any computer in the trust. So if you are on ward B19 and you want to log a task for the out of hours period, you're not coming to medical handover, you just log it in this way, and it will come up in the handover at the end of our handover. So once the actual handover on well patients is complete, and we've run through the handover protocol, the F1 and the SHO and the registrar covering the wards, and on nights just the SHO and the F1, log on to e-outcome, and they go through this list. They log into a handheld pager device, it's an iPhone, and then allocate these tasks to themselves. Throughout your shift then, any tasks that the nurses raise from the wards will also ping onto this device. So you've got your colleagues' medical handover tasks, and then you've also got the incoming nursing tasks as well. So it's all things in one place, so you can prioritise and triage those accordingly. Now the registrar doesn't carry a bleep, so we'll move on to the next slide. You can see here that the overnights, there's an SHO that carries, and weekends. Weekdays it's just an F1. The registrar doesn't at the moment carry an iBleep. That's because overnight we expect you to be in A&E for the majority of the shift. But we do ask that you keep a little look onto the system if you are the senior on duty, so that you know what your colleagues are up to and where the unwell patients are, just for your knowledge and safety for the team. So e-outcome task manager, this is the system that we call this bleep system. Here's a snapshot from our coordination on a Saturday at 4 p.m. And if you have a look at the top right corner there, I've circled that there's 50 tasks on the system. Now these are the surgical teams, orthopaedic teams and medical teams that are using this system. So this is combined for the specialties. But it's important, if you are the registrar, to know how many jobs your juniors are doing so that you can support them, and also any training opportunities you can pick out from those jobs. It's really good to bring everything together so that you're supporting your junior colleagues and helping them to learn. So it's all out a bit of IT, and it's quite difficult to explain it over a presentation. The IT team will support you as best as you can, and there's also some user guides. They're logged on the intranet. You can get them through the acute care team workspaces, and I think Chief Reg Damien Dewey has also printed out some user guides to hand out to you when you arrive. So if you haven't got one of those already, make sure that you do get one, because you'll need to refer to it while you're getting used to the system. It becomes second nature very quickly. So having covered all of that, that should be everything you need to know about the on-call period to get started here at Warrington Hospital. But if you have questions on handover day, so Wednesday the 5th of August from 8 till 8, I'm here on site all day to help go through anything that I perhaps haven't explained as well as possible. Normally I have lots of questions after this session that I can't answer by having to record a video for you. So I carry a page at all times, and if you want to speak to me today on handover day, I'm on 414. So feel free, I'm here specifically for this job today. Bleep me on 414 and I'll be able to either come and do a training session in person, show you how to put all this together, or anything I've not made clear, just let me know. Thank you.